بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. أعزائي أبنائي إخواني الطلبة، يتجدد بنا اللقاء مرة أخرى في محاضرة جديدة من سلسلة محاضرات Ophthalmology Made Easy. It's my honor to welcome you again in this session and this episode of the lectures of Ophthalmology Made Easy, which are targeting all postgraduate students either willing to appear in the FRCs or the Libyan board exams. The topic for today is very fantastic and very attractive topic, which is the limbal stem cell deficiency. Now, this topic is not just reflect the advances in the medicine and the scientific advances in this regard, but also it is a reminder for us for the profound wisdom behind our body design and the incredible power of our God that He places in our body a tiny small cells, nearly seen, very small cells that are capable for the regenerative power of our tissue. So our topic for today is not just a scientific advances only, but also it is a reminder for us to feel thankful and merciful for our God that He's responsible for placing these tiny small cells in our body that capable for regenerating our tissue. Now in this lecture we will dive and see what's the meaning of stem cells, what are the different types of stem cells, what are the classifications, and what's known as the XYZ hypothesis. Also, we will see the clinical signs and symptoms and how we are going to investigate a patient with limbal stem cell deficiency. And lastly, we will speak about the recent advances in this field. So let's dive deeply and see what's inside this lecture. Now, as usual, we will start with the learning objectives of this lecture. We have plenty of tasks from this lecture, including the definition, anatomy, and the XYZ hypothesis of the limbal stem cells, and also defining certain important terminology like the limbal stem cell niche and the principle of stemness of limbal cells. And then we will enumerate the etiology of and the causes of limbal stem cell deficiency, and see some of the signs and symptoms of this disease and the classification and the diagnostic approach, including the impression cytology, confocal microscopy, and the anterior segment OCT. Then the classification and the management oriented to the classifications. And also we will speak about the different surgical approach for the management of this disease and some of the medical management. And finally, we will speak about the recent advances in the field of limbal stem cells, namely the bioengineered cornea and the gene therapy in this type of diseases. So let's dive deeply and start with the first three options together. That is the anatomy of the limbus and limbal stem cells and the principle of XYZ hypothesis and the definition of limbal stem cell niche and stemness of the limbal stem cells. Starting with the cornea, as you know, the cornea is the outermost transparent part of the fibrous coat of the eye, and it constitutes 2/3 of the dioptric power of the eye. And it contains mainly three cellular layers, that's the epithelium, stroma, and endothelium, and two acellular layers, that's the Bowman's membrane and the Dismas membrane. Now, what's important for us in this session is that the limbus. Now, the limbus, as you can see, is the transitional zone between the conjunctival epithelium and the corneal epithelium, so that the stem cells are placed in the basal layer here. And as you can see, these cells, upon stimulation, they will start to proliferate, migrate, and differentiate to cover any defect and maintain the homeostasis of the cornea. Now, if we speak about the limbal stem cells, as you can see, the limbal stem cells are present in the basal layer at the junction between the conjunctival epithelium and the corneal epithelium in a crypt-like folding of the conjunctiva known as the palisades of Voges. Now, in the basal layer of this palisades of Voges present the limbal stem cells, which are undifferentiated pluripotent cells. These cells are present in a radial enfolding, which is more prominent in the inferior limbus as compared to the superior limbus. Now these limbal stem cells, when we look to the cell cycle, upon stimulation, these limbal stem cells will proliferate to a daughter stem cell and a transient amplifying cells. Now the daughter stem cells important to maintain the normal population and maintain the normal balance of the stem cells based on the XYZ hypothesis that we will speak about it later. And the transient amplifying cells, now these cells will migrate centripedially toward the center of the cornea or toward the area of the lesion or the insult, and then will differentiate to a post-mitotic cells. And these post-mitotic cells also will migrate to the surface to form the terminally differentiated cells, which later on will be shed and disintegrated into the tear film. So this is the normal cell cycle of the limbal stem cells. Upon stimulation, it will migrate from the limbal area in a centripetal fashion, then towards the surface, transferring from transient amplifying cells to a post-mitotic cells, and finally to a terminally differentiated cells. Now, since we are speaking about the stem cells, there are certain terminology and definitions we should understand before we dive deeply into the stem cell treatment or the stem cell deficiency. Now, the term which is known as the totipotent stem cells. What's the meaning of totipotent stem cells? Now, totipotent stem cells, this is the most versatile type of stem cells that can give rise to all the embryonic and extra-embryonic tissues. It means that it gives rise to the organism itself, that's the baby, for example, and the extra-embryonal tissues like the placenta. And the most common and typical example is the zygote or the first few divisions up to the 8-cell stage. And this type of cells are not allowed or difficult to grow in culture because of from technical reasons as well as from ethical point of view. So the most common is the zygote. And for us as ophthalmologists, the ocular relevance, there is no not directly used in the eye as regenerative cells due to the ethical reasons as we have spoken before. So the most common example is the zygote. Now, the other type of cells, which is known as the pluripotent stem cells. Now, the pluripotent stem cells, these are the cells that can differentiate into the 3 germ layers that can form the endoderm, mesoderm, and ectoderm. So they will form the core organism, but will not form the extra-embryonal tissues, that's the placenta. So the pluripotent cells will not form the extra-embryonal structures. And the example of this pluripotent stem cells is the blastocyst, that's the 7 to 8 days cell line that is seen in after the zygote formations. And an example of these pluripotent cells in ophthalmology, what's known as the induced pluripotent stem cells. This is the induced pluripotent stem cells can be used in ophthalmology, and this induced pluripotent stem cells, they can form regeneration or they can form retinal pigment epithelium and can form the corneal epithelium as well as the photoreceptors. Still, these are under the experimental methods for regenerating the retinal pigment epithelium and the photoreceptors. So used as experimental retinal regeneration and limbal stem cell therapy and corneal epithelial reconstruction. However, still the pluripotent stem cells is not used clinically or practically, but is used under experimental level only. So the totipotent and the pluripotent stem cells practically still not used in ophthalmology. However, what we are using in the ophthalmology is the multipotent stem cells. Now, the multipotent stem cells, cells that can differentiate into multiple cell types, but only within a specific germ layer or tissue lineage. It means that these cells are capable for multiplying and forming different other different cells within the same tissue. It will not form another tissues or another structures. For example, these cells are found in the limbus that we are speaking about. They are found in the neural tissues and the bone marrow. And the most common example is the limbal epithelial stem cells. Now, the limbal epithelial stem cells will give rise to the various types of the corneal epithelial cell types and all the mesodermal, other stromal cells that's present and supporting the corneal epithelium. Another example of the multipotent stem cells is the mesenchymal stem cells. And also now there is a experiments on this type of cells to generate the corneal epithelial cells. Normally these cells will form the bone and the fat and the cartilage. So as the name implied, the multipotent, they form multiple different cell types, but within the same tissue lineage or within a specific germ layer. Now, the ocular relevance, as we said, that the limbal stem cells are multipotent stem cells that help in the corneal regenerations, and the mesenchymal stem cells used in as anti-inflammatory therapy and in ocular surface diseases. Now, the final or the last one or type of stem cells, which is the unipotent stem cells. Now, these unipotent stem cells are capable for self-renewal and regeneration, but they form only one specific cell line. And the most common typical example is the basal layer of any epithelial cells. As you know, the basal layer will multiply and proliferate and migrate to the surface and form just only the corneal epithelium, for example, but it will not differentiate to another type of cells. So this is called unipotent stem cells. The same thing present in the muscles, that one type of cells they will end up with one forming only the skeletal muscles. Also, this type of cell is rarely used in ophthalmology as therapeutic use, but it is important in local tissue turnover and repair. So what's important for us is the multipotent stem cells. So when we speak about the limbal stem cells, we use them because of its property as a multipotent stem cells that capable for renewal and regeneration, and it will form many different cells within the same tissue lineage. Now let's speak about the limbal stem cell deficiency. Until recently, there is no general agreement about the definition of limbal stem cell deficiency until the global consensus meeting established by the Corneal Society meeting at 2019 that places the ground for the criteria and the standard criteria for defining limbal stem cell deficiency. And it was defined as an ocular surface disease, which is caused by decrease in the population and the function of the corneal epithelial stem progenitor cells. This decrease will lead to the inability to sustain normal homeostasis of the corneal epithelium. So limbal stem cell deficiency is an ocular surface disease characterized by decrease in the function and the population of the epithelial stem cell progenitor, leading to defect or abnormal homeostasis of the corneal epithelium. And the key characteristic features of this disease, as you can see later on, that there is a primary feature of this disease, which is the conjunctivization of the corneal epithelium, because the limbal stem cells act as a barrier to avoid or prevent the overgrowth of the conjunctival epithelium over the cornea. And in the presence of deficiency in this limbal stem cells, the primary feature is when you find conjunctivization of the surface of the cornea. This is a very strong marker for limbal stem cell deficiency due to replacement of the normal corneal epithelium by conjunctival epithelium. And along with this conjunctivization of the corneal epithelium, there will be loss of the epithelial function with persistent and recurrent epithelial defect, which may occur with or without neovascularization. Also, ocular surface inflammations and scarring. Any cause of limbal stem cell deficiency will lead to recurrent corneal epithelial defect and subsequent scarring of the ocular surface. And as a result of these two problems, there will be a consequent decrease in the vision and discomfort, leading to reduced the quality of the health of the patients, and the patient will start suffering from various symptoms, including ranging from the pain and discomfort and foreign body sensation, ending up with scarring and the marked diminution of the vision. And the clinical features is based on the extent of this limbal stem cell deficiency, whether is it total or partial stem cell deficiency. The clinical feature will depend on the extent of the involvement of the limbal stem cell deficiency. If it is partial, there will be mild symptoms. However, if it is total, there will be significant symptoms. Keeping in your mind that keratoplasty does not treat limbal stem cell deficiency. Keratoplasty is not a treatment for limbal stem cell deficiency, as these patients, if they underwent keratoplasty, they will have for definite rejection. So we have to treat or do limbal stem cell transplantation rather than total corneal transplantation. Now let's speak about the XY hypothesis that's postulated by Foss and Friend at 1983, who postulated that there is an equilibrium between the amount of cells that shedded from the surface of the corneal epithelium, that's the terminally differentiated cells, and the cell proliferation and migration that happens at the level of the basal cell layers, that's the stem cells. And there will be both, there is a centripetal and centrifugal movement of these cells. So upon stimulation, the limbal stem cells, they will initiate a proliferation and migrations, which constitute the X-axis, and there will be a centripetal migration toward the center of the cornea, that's the Y-axis. Now the combination of this proliferation and migration in both X and Y axis should equal to the amount of shedding of cells that happens on the surface of the cornea, that's correspond to the Z axis. So this is what's meant by the XYZ hypothesis. So if we see in this diagram, this is the mother stem cells that divides into a daughter stem cells and another transient amplifying cells. Now the daughter stem cells will keep the population of the normal stem cells, and the transient amplifying cells will have to migrate in the Y-axis, so that it will propagate from the limbus toward the center of the cornea, and then it will undergo differentiation and migration toward the apex of the cornea through the X-axis. So this is the mitotic cells that propagate in this X-axis, so that it will end up by reaching to the terminally differentiated cells. And from the surface of the cornea, these cells will disintegrate and will be shedding, so that this is correspond to the Z-axis. So normally, for normal corneal homeostasis based on the Foss XY hypothesis, the combination of both the X and Y axis migration and proliferation should correspond to the amount of shedding that happens on the surface of the cornea. Now this video, I will explain briefly how this process takes place. As you can see, this is a section through the limbus, and this is the basal layer where there's stem cells present in this layer. Upon stimulation due to any corneal pathology or corneal injury, these cells will proliferate, and then, as you can see, there is migration in the Y-axis, so that it will go toward the center of the cornea, as well as there will be migration towards the surface of the cornea, that's along the X-axis. So this is what's meant by the XYZ hypothesis. Now, in completion to the detailed anatomy of the limbal area, and on the context of the limbal stem cells, we shouldn't forget to mention about the limbal stem cell niche from a histological point of view. Now, this term or this definition is very important for us when we plan for ex vivo expansion for these cells. So the limbal stem cell niche refers to the specialized microenvironment present at the limbus, which plays an important role in maintaining and regulating the limbal epithelial stem cell proliferation. What's the components or the structure of this limbal stem cell niche? It is made up of the limbal stem cells, which is placed in the cryptus within the palisades of Vogel's. We have mentioned before that the palisades of Vogel's, which is radially oriented fibrovascular ridges, believed to host the limbal stem cells. Also, it contains the extracellular matrix and the stromal cells that, in combination with the basement membrane, that provides the structural support and the biomechanical signals for these cells. And the niche cells is the mesenchymal cells, melanocytes, and immune cells. Now, it is not surprisingly that you find plenty of melanocytes in this area, because they thought that it provides protection against ultraviolet for these precious cells, that's the limbal stem cells. So the limbal stem cell niche is basic structures that is present in the limbal, in the palisades of Vogel's, namely within the cryptus of the palisades of Vogel's, which represent the microenvironment for the limbal stem cells. Now, what's the function of this niche? As I said, that it is very important to maintain the stem cell quiescence, and this means that it prevents the premature differentiation. As we said, that the limbal stem cells stay throughout life, and it provides daughter cells that maintains the healthy and the homeostasis of the corneal epithelium. So they became dormant till it is stimulated by special signals. So maintaining this quiescence of these cells is maintained by the limbal stem cell niche. Another thing, it supports the asymmetric division. So it means that one stem cell, when one stem cell divides, it provides one transient amplifying cells and one daughter cells to maintain the population of the limbal stem cells. Another thing, it protects from oxidative stress and inflammations, so that presence of these cells within the cryptus, within the palisades of Vogel's, help to protect these cells from being exposed to the inflammation and damaged by any immunological reaction. Now, if you look in close proximity to these limbal stem cells niche, you will find that these cells are very well protected within these crypts of the palisades of Vogel's, and also it is mainly present in the 12 o'clock and 6 o'clock position, which is protected by the eyelids. And this is not just by chance, but this is because these cells are primarily present in large concentration in these areas to be protected from ultraviolet or from any mechanical damage. And apart from this, the presence of melanocytes, as I said, provide protection against ultraviolet light. Now, this is important for us when we plan for an ex vivo expansion of these cells for any sort of treatment. If we could take the biopsy from these limbal stem cell niche and expand them in a amniotic membrane, so that this will help to maintain the microenvironment of these cells and also proliferation of these cells and the production of a basement membrane, and this cells becomes ready for transplantation to the recipient eye and treat whatever pre-existing limbal stem deficiency, limbal stem cell deficiency. So if we plan to do a biopsy for limbal stem cells, better to take it from the limbal stem cell niche, which is present mainly in the 12 and the 6 o'clock position. Now, after we have spoken about the anatomy of the limbus and the anatomy of the limbal stem cells and the location where they are reside in the basal layer of the palisades of Vogel's, now it's important to understand what's the main role of these cells, especially in maintaining the homeostasis of the corneal epithelium. One of the main functions is to maintain the corneal transparency by continuously regenerating the epithelium, so it can contribute to the epithelial development and homeostasis. So any damaged or abnormal epithelium will be discarded and replaced by new epithelial cells. Another important rule that they act as a barrier to prevent the conjunctival epithelial cells from encroaching onto the corneal surface. So it is a barrier between the corneal epithelial cells and the conjunctival epithelial cells. So by cell-to-cell contact inhibition, it prevents the overriding of the conjunctival epithelium over the corneal epithelium. Because you know that the corneal epithelium has special identity, non-keratinized corneal epithelium. It's very important, this phenotype of corneal epithelium, to maintain the optical function of the cornea, to prevent the scattering of the rays and concentrate the light into the retina. So if we change the corneal epithelium with conjunctival epithelium, this function is no more maintained, and this will have optical consequences that affect the visual quality of the patients. Another important role for the limbal stem cells is its role mainly in the healing process that happens when there is any conjunctival corneal abrasions or corneal ulcers. It has a major role in the healing process through their potential capacity for rapid proliferation and differentiation into a mature corneal epithelial cells. So the main rule and the main function of the limbal stem cells can be summarized in these three major rules, that is maintaining the corneal epithelial homeostasis, maintaining the corneal epithelial transparency, and plays an important role in the healing process and act as a barrier between conjunctival epithelium and corneal epithelium. Now, after understanding the role of the limbal stem cells in maintaining the corneal homeostasis and acting as a barrier between the conjunctival and corneal epithelium, and its role in the healing process of any corneal damage, now the power that provides these cells to maintain all these functions and to maintain the corneal homeostasis is known as the stemness of the limbal stem cells. Now, this concept is very important to be understood because this term is frequently encountered when you read about the cell-based therapy for limbal stem cell deficiency. When we come to the management of the limbal stem cell deficiency, and we will speak about the cell-based therapy to maintain the corneal homeostasis. So the term stemness is a very important term to be understood, which reflects the power of these limbal stem cells to maintain and provide all the functions that we have outlined before. So the ability of the limbal stem cells to exert its power in proliferation and maintaining the corneal homeostasis is known as stemness of the limbal stem cells. So what's the meaning of the stemness? Stemness is a self-renewal ability of the limbal stem cells that it will divide, replicate over a long period of time without losing their undifferentiated state. As you know, the limbal stem cells are undifferentiated cells. They are not differentiated cells. That's why it has the potential and the capability for dividing and replication and later on differentiated to an epithelial cells. So its ability on over a long period of time for division and replication, this is one important factor that contribute to its stemness. Another thing that the limbal stem cells has the potential for differentiation for different types of corneal epithelial cells. This is called as multipotency. And this ability of these stem cells to differentiate to different epithelial types of epithelial cells, like the cuboidal cells, the marginal cells, the superficial epithelial cells, and so on. So this is another factors that is related to the stemness of the limbal stem cells. Another factor related to the stemness is the clonogenicity. Now, by clonogenicity, it means the ability of these cells to colonize on the culture media. When they are placed ex vivo in the culture media, they will form colonizations of these stem cells. This ability also is related to its stemness. And finally, it has the potential and the ability for being quiet for a long period of time until it get activated by any stimulus. The stimulus for activation is, of course, the corneal injury. So all these features describes the ability or the stemness of the limbal stem cells by their colonization ability, by their quiescence and inactivation ability, and their potency for differentiated to different epithelial cells, and their ability for long-term proliferation to maintain the corneal homeostasis. So this term I like just to emphasize on it because you will face it when we speak about the cell-based therapy for limbal stem cell deficiency. Now, since we have spoken about the concept of stemness of limbal stem cells, it is mandatory that we mention the important biomarker that is regarded as an important parameter to evaluate the degree or a quantitative assessment of the degree of stemness of the limbal stem cells. Now, how we can quantify the degree of stemness of limbal stem cells? All of us, we agree that the more the stemness of the limbal stem cells, the more the capability and the potential for regeneration and maintaining the corneal homeostasis. Now, there is an important biomarker, which is the P63, which is regarded as one of the main important biomarkers that reflects the stemness of the limbal stem cells. And when we have a high expression of these biomarkers, it correlates well with the regenerative power and the stemness of the limbal stem cells. It plays an important role in renewal and proliferations and survival of the undifferentiated limbal stem cells, also in the regeneration of the well-differentiated epithelial cells. So in any ex vivo expansion or cells present in the lab associated with high expression of this P63, and you find high levels of the P63, it correlates well with the very successful growth of the limbal stem cells ex vivo. And in many studies, they found that if you the presence of less more than 3% of the P63 level in the limbal epithelial graft, it has a very predictive marker for successful limbal stem cell transplantation. And if you find more than 5 or 10%, it means that your graft is very, very successful. So in summary, the P3663 biomarker is essential to identify, maintaining, and predicting the success of your human limbal stem cells in both physiology and physiological and clinical applications. So this biomarker correlates well with the meaning or the concept of stemness. Stemness means high expression of this biomarker P63. So you should keep it in your mind. You will face it in any discussion regarding limbal stem cell stemness, or in any MCQ or any discussion regarding the ability of the stem cells to proliferate and maintain corneal homeostasis. Now for the postgraduate students, this is important to memorize this protein, that's the P63 proteins. And what's important to memorize that there are two isoforms of these proteins, the TAP63, which act as a tumor suppressor that dampens and prevent the cell cycle and arrest the apoptosis, so that prevent premature proliferation of the stem cells. And the other one, which is the delta NB63 isoform, which act as an oncogene, which involves in stimulating the self-renewal and the promotion of proliferation of the cells. So the limbal stem cells present in a balance between these two proteins, and the finding a high expression of these proteins is a marker for quiescence of the epithelial cells. However, expression of large quantity of these proteins indicate active proliferation of the limbal stem cells. Now, for you as a postgraduate student, what you need is just to memorize this protein and to know the difference between these two, which is one is a tumor suppressor and the other one is an oncogene. Now, after we have finished speaking about the definition of limbal stem cells and the different terminology like the XYZ hypothesis and the principle of stemness of limbal stem cells, now it's the time to speak about the etiology of the limbal stem cell diseases and elaborate the different clinical signs and symptoms and discuss in details the differential diagnosis of limbal stem cell deficiency. Now we come to the causes for the limbal stem cell deficiency. The causes ranges from primary idiopathic causes to a secondary known causes. The primary idiopathic causes, the top is the aniridia and congenital erythrokeratosis, and also keratosis associated with multiple endocrine diseases and neurotrophic keratitis, and also diseases of chronic limbitis or idiopathic autoimmune limbitis. The secondary causes, there are multiple secondary causes. At the top is the chemical injuries, especially the acid and alkali injuries, and also any other thermal injuries, Stevens-Johnson syndrome, and any autoimmune inflammations, and also the contact lens wearers and extensive microbial infections that lead to damage to the limbal stem cells. So there are plenty of these secondary causes. I have summarized this in this diagram. This shows the various causes of the limbal stem cell deficiency. Of course, in the top is the hereditary idiopathic causes, and this is the list for the secondary causes, ranging from chemical injuries to the also limbal surgeries, any limbal surgeries like pterygium, also the prolonged use of contact lenses, and infections with the use of antimetabolites, namely the mitomycins, also exposure to irradiation, and any chronic inflammatory conditions. All this can lead to deficiency and decline in the function of the limbal stem cells. Now we come to the clinical pictures and the diagnostic criteria for limbal stem cell deficiency. As you know, the most common symptoms for patients with limbal stem deficiency based on the level and the degree of limbal stem cell deficiency. That's to say, is it a mild degree, partial, or total limbal stem cell deficiency? So the symptoms are a broad range of symptoms ranging from the simple photophobia, redness, foreign body sensation, tearing, dryness, and ocular discomfort, and sometimes pain. Symptoms can range from mild to severe based on the degree of affection of the limbal stem cells. Now, what are the diagnostic criteria that we should rely on to diagnose this problem? The first thing is the slit lamp examination. Now, by slit lamp examination, we have the what's known as the late fluorescein staining in vortex or punctate pattern. When we apply the fluorescein to the cornea, since the cornea is covered by unhealthy conjunctival epithelium rather than corneal epithelium, so these conjunctival epitheliums they don't have the tight junctions as seen in the between cells as seen in corneal epithelium. So there will be late leakage of fluorescein after 7 to 10 minutes after applying the fluorescein. So this is known as late fluorescein staining. And I will explain this in details in another slide. Another features that you can see in the slit lamp is the presence of recurrent, persistent, or recurrent epithelial defects and erosions, reduced epithelial transparency and irregularities. As you know, these limbal stem cells plays an important role in the clarity and transparency of the corneal epithelium. So you most likely, especially in advanced cases, you will find haziness and cloudiness of the cornea because of the conjunctivization of the corneal epithelium. So one of the main features of limbal stem cell deficiency, you'll find hazy cornea. Of course, conjunctivization of the cornea, as seen by growth of the conjunctival epithelium over the cornea, and also new vascularization with the growth of new vessels on the surface of the cornea. And you will find also in the limbal area, absence of the palisades of Voges, and also severe corneal scarring can be seen. Now, in this presentation, I will show you what the difference between partial limbal stem cell deficiency and total limbal stem cell deficiency. Now, for example, this is a case of partial damage to the limbal stem cells. So, in these situations, the residual available healthy limbal stem cells will take over the mission and start proliferate and move in along the x-axis and the y-axis to cover the defect and replace whatever has happened in the cornea after this chemical, for example, this chemical injury. So in the presence of partial damage, the remaining viable stem cells will heal the process and take over and end up with normal healthy cornea. However, in this video, as you can see, when there is severe damage to the limbal epithelium, the limbal stem cells, as you can see here, so there is no more any limbal stem cells. Now this is the conjunctival epithelium. They will grow, and there will be no barrier against their growth as before due to the presence of the limbal stem cells. Now this epithelium will grow and take over and encroach over the cornea, and also this will enhance a new vascularization of the cornea. This is the main difference between partial and total limbal stem cell damage or deficiency. As I have said before, that there are different diagnostic tests for limbal stem cell deficiency. Of course, we will come quickly on the symptoms and signs, as I have mentioned it before. The symptoms ranging from mild pain, foreign body sensation, photophobia, to a decreased vision and decreased quality of life, and recurrent epithelial defects. And the signs, as seen by the doctor, he will see the signs of conjunctivization of the cornea, haziness, irregularities, subepithelial fibrosis, loss of corneal palisades, and persistent epithelial defect and late fluorescein staining. Now, what's important for us is the diagnostic test. As I said, the late fluorescein staining, as I have explained before, is an important diagnostic test. And also the presence of certain histological biomarkers, impression cytology for goblet cells, scraping, biopsy, and also immunohistochemistry and gene expression in some rare genetic disorders like aniridia. And finally, the use of imaging, namely the anterior segment OCT angiography in the diagnosis of limbal stem cell deficiency. Now, this is some of the pictures showing the different degrees of limbal stem cell deficiency and at different stages. We will speak about the staging of the limbal stem cell deficiency in different slides. This shows extensive pannus formation with destruction of the nearly 360-degree damage to the limbal stem cells with the positive staining and late staining of the central part of the cornea. Similarly, here you can see extensive neovascularization and involvement of the central 5 mm of the cornea. So this is another picture. You can see extensive opacity and persistent epithelial defect with vascularization and subepithelial fibrosis, extensive neovascularization. So you can see that this is severe limbal stem cell deficiency. This is immunoimpression cytology for goblet cells that shows the presence of goblet cells in the surface of the cornea. This is another important diagnostic test, and it is a confirmatory test that shows the changes in the phenotype of the epithelial, the corneal epithelial to a conjunctival epithelial. This is called impression cytology. This is very important. Still in the context of the diagnostic tests, as I have said before, that the latest staining of the cornea is one of the main diagnostic tests seen by slit lamp to diagnose what's known as a paracellular permeability of the cornea due to conjunctivization of the corneal epithelium. In this diagram, I will show and explain how this paracellular permeability is increased. As you can see, this is a diagram showing the through special isotopes material they use to determine the permeability of the conjunctival epithelium and the corneal epithelium. You can see here, this is the corneal epithelium. It's very tight junction between epithelial cells, and there is no low or there is low permeability. However, in the conjunctival epithelium, they shows high permeability because of the lack of the tight junction between epithelial cells. And now, for example, now if we have, this is the corneal epithelium, as you can see the tight junction, and this is a conjunctival epithelium. And if we add a fluorescein drop over the surface of the cornea and keep it for a while, between 7 to 10 minutes, and after that you will see that the fluorescein is washed out and there is no intervening fluorescein between the epithelial cells. However, between the conjunctival epithelial cells, there is paracellular intervening fluorescein between the epithelial cells. And that's why the presence of late staining is one of the important diagnostic tests in using the slit lamp. This is an example of conjunctivization of the corneal epithelium with extensive neovascularization corroding from the periphery and central cornea. Also, they have epithelial defect and staining. Also, this is similar to complete loss of the limbal area with extensive pannus formation and vascularizations. And as you can see, this is the late staining that after you apply the fluorescein, there is a green hue here, which indicate the late staining due to conjunctivization. Now we come to an important session of this lecture, which is the differential diagnosis of limbal stem cell deficiency. Of course, there are plenty of diseases that can mimic the limbal stem cell deficiency as far as the symptoms and signs of the patients. However, the underlying pathology is completely different, and this is very important to plan the management for this patient. So there is a list of differential diagnoses that mimic limbal stem cell deficiency. One of them is the presence of chronic surface inflammatory diseases like chronic conjunctivitis or severe dry eye. Perhaps dryness or dry eye is one of the most important confounding variable that's confuse the picture of limbal stem cell deficiency, and actually it is usually present in most of the time along with the limbal stem cell deficiency. So it's very important for us to translate the signs and symptoms of the patients, whether it is just pure limbal stem cell deficiency or it is a pure dry eye or a combination of both. So we will discuss in details about how we will differentiate between dryness and limbal stem cell deficiency, because this is very popular and present in daily practice, and confusion in making the distinction between these two is very important, and also it is very dangerous if we miss a case of limbal stem cell deficiency and deal with it as a case of dry eye. Other chronic surface inflammatory diseases, as you know, the ocular cicatricial pemphigoid and Steven-Johnson syndrome. Other neurotrophic or infectious keratopathies like neurotrophic keratopathies, herpes zoster and herpes simplex. Of course, the most common also is the chemical injuries or post-surgical, chemical in the form of alkali or acid burns, and post-surgical, the most common is pterygium surgery, also glaucoma surgery, and contact lens wearers who induces some sort of contact lens induced keratopathies. And finally, a list of congenital and genetic diseases that we have mentioned before also contribute to the differential diagnosis of this disease. Now, in the current discussion, we will speak in details how we will differentiate between dry eye and limbal stem cell deficiency. The distinction is very important, and at the same time, it is difficult unless based on solid clinical background as well as some investigatory tools. Now, the clinical symptoms of the patient with dry eye, which ranges from burning sensation, grittiness, and vision usually deteriorates during reading or on watching the TV. And usually the deterioration is gradual and often bilateral in both eyes, which worsen as the patient grow up and upon exposure to the wind or in the hot weather. However, in limbal stem cell deficiency, the blurring is not related to the prolonged reading, but it is present all the time with irritation and photophobia and poor healing of the corneal irritations. Also, the symptoms are insidious and usually there is a history of injury or there is history of surgery prior to this complaints. So this is one important based on the history itself. Now, the other thing is regarding when we start to do examination of the patient and apply fluorescein, usually in the dry eye, which is very important, this sign is very important, you will find punctate staining of the cornea, which is usually in the exposed R, that's in the interpalpebral zone. So when you elevate the lid or retract the lower lid, you will find the cornea is intact. However, the exposed area, you will find diffuse punctate staining of the cornea. However, in limbal stem cell deficiency, there is a special pattern which is known as whorled staining, or sometimes named as vortex keratopathy, in which you will find the irregularities in the staining, especially in the superior and inferior cornea. So it is the reverse for dry eye. Dry eye, you find the staining in the interpalpebral area. However, in the limbal stem cell deficiency, you will find the staining mainly in the superior and inferior cornea. As far as the signs of conjunctivization seen by slit lamp, usually in dry eye, there is no signs of conjunctivization. However, it is present in the presence of limbal stem cell deficiency and is confirmed by the laboratory examination and finding a goblet cells on the surface of the cornea. Other things like the vascularizations, as seen by slit lamp, usually in dry eye, you will find mild superficial vascularization of the cornea. However, in limbal stem cell deficiency, you will find deep vascularization of the cornea that cross the limbus and can go beyond the limbus. Other differentiating feature is the limbus. Now, we have to concentrate on the limbus. In a dry eye, you will find the palisades of focus are preserved and present. However, in limbal stem cell deficiency, you will find loose or blunting of the palisades of focus, and also late staining of fluorescein. This is one important features. That is when we apply fluorescein, you will find late staining of the fluorescein in cases of limbal stem cell deficiency due to conjunctivization of the corneal epithelium. However, in dry eye, you find the staining in the interpalpebral area, which is immediately, it is not related to the time or late staining. So you'll find immediate staining or punctate keratitis in the interpalpebral zone. Another thing regarding the corneal sensitivity. Now, in dry eye, you may find reduced corneal sensitivity, especially in severe dryness. Many studies shows decrease in the subbasal nerve plexus. However, in limbal stem cell deficiency, often preserved and unless it is preceded by neurotrophic keratitis. So these are some of the differentiating features between dry eye and limbal stem cell deficiency. The last thing is related to the tear film assessment. Now, in dry eye, when you apply a Shermer test or tear film breakup time and osmolarity, you will find the diagnostic criteria for dryness. However, in limbal stem cell deficiency, you might find abnormal tear film, but the change is usually not proportional to the epithelial instability. So you will find advanced epithelial changes, but very minimal changes in the tear film. And the most important is the impression cytology. As I said, that you will find the goblet cells present or detected in the surface of the cornea due to conjunctivization and limbal stem cell deficiency. However, this is negligible or minimum in the presence of dry eye. And finally, the diagnostic test in response to the treatment. Now, if you apply lubricants, the patient will significantly improve in dry eye. However, in limbal stem cell deficiency, there will be minimum or poor response to lubricants. So these are the major differentiating features between dry eye disease and limbal stem cell deficiency. This is very important to keep it in your mind because the signs and symptoms of these two diseases are confounding and usually mimic each other. Now we come to the fifth objective of this lecture, which is the different investigations that we are going to do for the patient to confirm whether it is limbal stem cell deficiency or not, and also to exclude any other differential diagnosis for limbal stem cell deficiency. Now, as far as the laboratory investigation for a patient suspected of having limbal stem cell disease, the main investigatory points are the impression cytology and the use of high resolution in vivo confocal microscopy and the use of anterior segment OCT and the anterior segment OCT angio, and finally some biomarkers and molecular diagnostics. We will go one by one and discuss each one of these diagnostic tools. Now I will speak briefly on one of the important diagnostic tests for limbal stem cell deficiency. That's the impression cytology. This is considered the gold standard investigation in the diagnosis of limbal stem cell deficiency. And the technique is simply involves obtaining a sample of the exposed epithelium on a piece of filter paper, usually made up of nitrous acetate. And the area is analyzed by immunohistochemistry, looking for both conjunctival cells as well as goblet cell markers. Now, if you find conjunctival cell markers or goblet cells marker, this is indicative of limbal stem cell deficiency. However, sometimes in advanced diseases, you will not find especially goblet cell markers, so this will not exclude the presence of limbal stem cell deficiency. In the presence of extensive fibrosis, you might not find goblet cells marker, but this doesn't rule out limbal stem cell deficiency. What are the famous markers for that include the cytokeratin 7 and 13 for conjunctival epithelium, and the MUC1 and 5 for goblet cells. Now, take a home message that due to this low sensitivity and the lack of spatial resolution of this impression cytology, we cannot use the impression cytology for the staging of limbal stem cell deficiency. However, we utilize the in vivo confocal microscopy for staging, as it surpassed that of the impression cytology. So impression cytology is used for diagnosis and not used for staging. This is very important. And as I said, that goblet cells, they are hyperreflective cells that are arranged in rosettes, and sometimes in advanced diseases you will not find them, and this will not rule out the presence of advanced limbal stem cell deficiency. Now it's the time to speak about the use of in vivo laser scanning confocal microscopy as a diagnostic tool for the early detection of limbal stem cell deficiency. This technique, which provides the high resolution images of the ocular surface at the cellular level, is a very powerful tool to evaluate the microstructure of the cornea. This technique has gained popularity among clinicians as a method to evaluate the various physiologic and pathologic changes that happens in the cornea and the conjunctiva and also in the limbus. As you know, if we rely mainly on the clinical finding on the slit lamp, a lot of finding will be missed, especially in early cases. And as far as the immersion cytology and the detection of goblet cells, also this is not highly specific because the goblet cells can be seen in the cornea in different other different diseases other than limbal stem cell deficiency. And as I have mentioned before, that in advanced limbal stem cell deficiency, the fibrosis will predominate, and sometimes you will not find a goblet cells present in the cornea. So to have a specific and sensitive tool to examine the microstructure of the cornea and determine the classification also of the limbal stem cell deficiency, we need for such a high resolution imaging like the in vivo confocal microscopy for the visualizing the cornea at the cellular level and in a real time, so that it provides a valuable adjunct to the diagnosis of limbal stem cell deficiency, particularly when the clinical signs are very early and very subtle and confounded by the scarring and the inflammation, as I said earlier. So if you can see, this is the picture of a normal confocal scanning microscopy for both the wing cell layer, basal cell layer, and subbasal nerves. Now, the subbasal nerves is very important for us because it is highly sensitive and highly specific for limbal stem cell deficiency, and it is an early pathognomonic sign that even predates the occurrence of conjunctivization and new vascularization of the cornea. So you can see here, this is the normal cornea and this is the abnormal cornea in a patient with limbal stem cell deficiency. The decreased density of the subbasal nerve plexus, as you can see here. Also, the changes that happens in the basal layer of the epithelium, which became indistinct border and prominent nuclei, as you can see here. Similar changes happens in the wing layer. As you can see, this is the normal polygonal appearance of the wing layer of the epithelium. However, here the borders become indistinct and they lose the normal shape and the architecture of the wing cells of the cornea. So these are all features of limbal stem cell deficiency based on the in vivo confocal microscopy. So what are the main features that we rely on the diagnosis of limbal stem cell deficiency using these techniques? The first thing, we have to comment on the basal epithelial cell morphology. This is very important because this is the place where we find the niche of the limbal stem cells and also the cryptis and the palisades of Vogel's. So you will find absent or replaced conjunctival epithelial-like cells, and the nuclei becomes more prominent. As far as the goblet cells in the corneal epithelium, this is the pathognomonic for conjunctivization of the cornea. And as I said, this is a late sign, it is not an early sign. The most important is the presence of subbasal nerve plexus density, reduction in the density of subbasal nerve plexus, and also the sum of the inflammatory cells like the Langerhans cells is slightly elevated. And also some changes in the stroma characterized by reduction of the cryptis and the palisades of Vogel's and the scarring also. So all these are the features of limbal stem cell deficiency in the presence, using the in vivo focal microscopy. This is another picture for the different levels of limbal stem cell deficiency. This is for a normal eye. You can see the normal architecture and the phenotype of the corneal epithelium with very clear, distinct borders. And then as the severity of the limbal stem cell deficiency increase, you will find the borders become indistinct and the cell size increase and prominent nuclei. And as you can see here, in advanced disease, nearly there is loss of the phenotype appearance of the corneal epithelium. And the same thing for the limbus. As you can see here, this is the palisades of Vogel's and the cryptis that's seen in the limbal area. And as the severity of the disease, there will be loss of the normal corneal architecture and end up by advanced disease by loss of the corneal palisades of Vogel's and also infiltration of plenty of epithelial cells. After this discussion, we come to the important home message that you should memorize and keep it in your mind as a postgraduate candidate that might be facing such discussion with the examiner in the oral exam or in the clinical exam regarding the finding that you are willing to look for using in vivo confocal microscopy. You should comment on the loss of palisades of Vogel's and also the presence or absence of conjunctivization of the cornea, because as I said, the high resolution feature of this technique that enable assessment of the cornea at the cellular level, and the pathognomonic feature of the loss of the density of the subbasal nerve plexus, along with the epithelial changes in the form of indistinct borders, prominent nuclei, and regular shape of the cornea, and along with the stromal changes. The other thing that, as I said, the subbasal nerve plexus shows a very high sensitivity and specificity for limbal stem cell deficiency, and it is useful in early prediction of the conjunctivization and precede also neovascularization. Now we will speak about one of the recent modalities that's used in the diagnosis or imaging of the corneal epithelium and the corneal limbus, which is known as the ultra high resolution anterior segment OCT. This ultra high resolution because it uses a broadband light source between 800 to 1300 nanometer, which provides a very high axial resolution ranging between 1 to 3 microns. And this is far superior to the standard anterior segment OCT, which provides a resolution between 5 to 10 microns. This make this technique very suitable for long-term assessment because it is non-invasive, non-contact, and provide detailed histological appearance of the cornea, limbus, and the conjunctiva. And that's why it is named as optical biopsy. It's provide an optical biopsy. So what are the advantages of the use of the ultra-high resolution in the diagnosis of limbal stem cell deficiency? As I said, because it is a non-invasive, so it is suitable for long-term monitoring and also useful in early detection where the clinical signs are still very minimum. So in suspicious cases where the clinical signs are not evident by slit lamp examination, so it is useful for early detection. And this is also important for mapping and planning the surgical intervention that we are going to do. So it provides a histological picture of the limbus and the corneal epithelium. And this is also helpful in staging and classification of the degree of limbal stem cell deficiency. So what are the things that we are going to see in the ultra high resolution? We will see the limbal epithelial thickness. This is very important sign that if you find decrease or irregularity of the limbal epithelium, this is early sign of limbal stem cell deficiency. Also, what's known as the epithelial transition zone. Normally, there is what's known as a transition zone between the conjunctival epithelium and the corneal epithelium. And this zone gets absent or replaced by conjunctival epithelial pattern over the cornea if the patient has advanced disease of limbal stem cell deficiency. Another important sign is the subepithelial fibrosis and inflammatory features. Subepithelial fibrosis will appear in the picture as hyperreflective band below the epithelium. Now, if you look to these pictures, for example, this is the normal anatomy of the cornea as seen by anterior segment OCT. You can see the hyperreflective band of the epithelium, very thin band, and then the hyperreflective band of the stroma. However, in the presence of this hyperreflective band below the epithelium, this indicates subepithelial fibrosis, which is one of the features of limbal stem cell deficiency. Now we come to another important tool used in the assessment and staging and diagnosing limbal stem cell deficiency, which is a very important non-invasive and non-contact method, which is the anterior segment OCT. As you know, there is a traditional anterior segment OCT and there is anterior segment OCT angio. And the difference is that in the anterior segment OCT angio, it is adding another information or additional information by comparing the decorrelation signals between two successive scans so that it will provide information about any moving particles, namely the RBCs. So it will provide three-dimensional picture for the blood vessels present in the limbal area. So the anterior segment OCT is a very important and indispensable ocular imaging modality, nearly used as a routine procedure in most of the comprehensive clinical practice. And it's provide a three-dimensional image of the cornea and its detailed structure, namely the corneal epithelium, the stroma, and also the detailed architecture of the limbal area. And as you can see in this picture, this is the picture of a normal corneal cornea with a normal OCT picture of the cornea. As you can see here, the normal corneal epithelium and the normal stroma. However, when you look to this picture, you will find decreased thickness of the corneal epithelium and normal stroma, but there is subbasal fibrosis. This line indicates subbasal fibrosis, which is an important finding in the presence of limbal stem cell disease. As you know, the cornea maintains its transparency by a very strict balance between the angiogenic and non-angiogenic factors. And also, you know that the cornea maintains its immunologically privileged state by presence or absence of new vessels. So in the presence of new vascularization, this will disturb the immunological privileged state of the cornea and endanger or threaten any future or subsequent corneal transplantations or any cell-based therapy that we are planning to do for limbal stem cell deficiency. So in a brief, that the anterior segment OCT, the traditional one, visualizes the epithelial thickness and the changes that happens in the limbal architecture, and also it helps to detect the residual limbal epithelial cells and the changes in the vogus, palisades of vogus and the cryptus of the limbus. However, the anterior segment OCT angio dealing mainly with the vasculature and the extension of these blood vessels and the depth of these vessels and all the information needed which reflect presence or absence of ischemia to the limbus due to any other causes like chemical injuries. So the various metric that we are used to quantify the limbal stem cell disease based on the anterior segment OCT angio, as you can see here in this diagram, one of them is the corneal vascular extension. Now, the corneal vascular extension refers to the extension of the blood vessels from the limbus towards the cornea. And we have three grades, stage 1, stage 2, stage 3, based on the extension of the blood vessels toward the center of the cornea. Also, another important metric is the corneal vascular thickness and the depth penetration of the blood vessels from the superficial to intermediate to the deep layers. Also, we have 3 levels on 3 stages. And the importance of these metric values they are correlated well with the severity and the staging of the disease, and also with the visual acuity or potential visual acuity of the patients. So by knowing these informations, it gives very good insight regarding the prognosis of your patient, as well as the chance of success of your transplantation that you are willing to do for your patient. So in conclusion, or before the conclusion, you can see in this picture, this is anterior segment OCT angio for a control patient and patient with different stages of limbal stem cell disease. As you can see here, the detailed vasculature is very well seen by the OCT angio. For example, you can see here, there is a patch of new vascularization here, which is very clearly seen with the OCT angio. So based on this extension, we can classify this as a stage 1. However, when you see here, the extension is much more inside. So this is a stage 2. And this is advanced penetration of the blood vessels reaching up to the central 5 mm from the cornea. So this is regarded as a stage 3. So finally, the anterior segment OCT angio enables quantitative and objective assessment of the limbal stem cell disease by measuring the corneal vascular extension and thickness, which correlates strongly with the disease severity and visual function. These parameters provide reliable biomarker for diagnosis and staging of limbal stem cell disease. So from this, you now realize the importance of anterior segment OCT angio in the assessment, staging, and planning for treatment for limbal stem cell disease. Now, to sum up what we have said earlier regarding the step-by-step diagnosis of limbal stem cell deficiency, of course, the first thing starts from your clinical examination and the clinical history. Detailed history should be taken from the patient regarding any history of trauma, history of chemical exposures, or history of any surgery done to his eyes, and the detailed symptoms and signs that he's feeling. The other thing, comprehensive eye examination, especially using the slit lamp, concentrating onto the appearance of the cornea and appearance of the limbal area, and seeing the cryptis or the palisades of Bogart's, and staining with the fluorescein, and see if there is any signs of late staining, signs of neovascularizations or conjunctivization of the cornea. All this should be noted. Another thing that, of course, as I have said, the use of anterior segment OCT, either the traditional one or the anterior segment OCT angio or the ultra high resolution OCT, scanning for the epithelial thickness, any subepithelial fibrosis, the stromal reflectivity, and the presence or absence of neovascularizations. Also, the presence of decrease in the density of the subbasal nerve plexus, concentrating on the limbal area, looking for the density of the stem cells, thickness of the epithelium, the cryptis or the palisades of Bogart's. All these are very important to assess and diagnose and pick up early cases of limbal stem cell deficiency. Now, if you are in suspicion and you are still not in a solid ground to say that this is a case of limbal stem cell deficiency, better to refer the patient, if it is available in your country, to a very specialized corneal center where there is the facility for in vivo confocal microscopy, and to perform also the immersion cytology to detect goblet cells on the surface of the cornea, and also to do some molecular tests to determine some of the biomarkers for the epithelial cells. This is for sure will provide a very high sensitivity and specificity for more than 98% of the cases that can be diagnosed by these facilities. Now we come to the sixth point in our learning objectives of this lecture, which is regarding the classification of limbal stem cell diseases. Now, based on the International Limbal Stem Cell Deficiency Working Group, which published a landmark which known as the Consensus Statement in 2019 to standardize the definition and the diagnostic criteria and even the staging of the limbal stem cell disease. So they advise to follow the staging system that's made by them to plan for the management of the case. So in the next discussion, we will speak about the staging and the grading of limbal stem cell deficiency. There are different levels. However, we will assume and adopt the staging made by the International Limbal Stem Cell Deficiency Working Group. Now we come to the staging of the limbal stem cell deficiency. Apart from the definition that we have spoken before, that's made by the International Classification and International Working Group regarding the limbal stem cell deficiency, the staging is very important to plan for the management of the limbal stem cell deficiency. Now, the staging is divided into two parts. The main staging is stage 1, stage 2, stage 3, and these are based on the status of the central 5 mm zone of the cornea. However, the substaging A and B and C is related to the limbal involvement. So, for example, when we say that this patient has a stage 1 limbal stem cell disease, so the central 5 mm zone of the cornea is normal. However, it can has less than 50% involvement of the limbus, so it is labeled as stage 1A. And for stage 1B, it has more than 50% involvement of the limbus, but less than 100%. And for stage C, there will be 100% involvement of the limbus. So you can see that here you might find a patient with 100% involvement of the limbus, but still he has a normal epithelium in the central 5 millimeter zone. Now for stage 2, there is mildly affection of the central 5 millimeter zone, and or similarly, it can be also has a stage A that is less than 50% involvement of the limbus, or stage B that is more than 50% but less than 100% involved with the limbus. As you can see here, there is no C substaging. Now for stage 3, there is entire involvement of both the limbus and the central 5 millimeter zone of the cornea, so there will be no further substaging. So this is based on the international classification done by the International Working Group for Limbal Stem Cell Deficiency. So I would like here to just emphasize that for staging 1 and 2 and 3, it is related to the status of the central 5 millimeter zone of the cornea. So for stage 1, as I said, there is normal central 5 millimeter zone. For stage 2, there is partial or mild affection. And for stage 3, there is total involvement of the central 5 millimeter zone. However, the substaging A and B and C is related to the limbal involvement. For stage A, it is less than 50% involvement of the limbus, and for stage B, between 50 to 90% or 95% involvement, and for stage C, there is total involvement of the limbus. Now, after finishing the staging system made by the International Working Group, now we will speak about the grading. As I said, that the grading reflects the functional impairment of the visual function of the patients due to either presence or absence of inflammations, or due to involvement of the visual axis or the central 5 degree. So grade 1 indicate mild disease, and in this case, the central 5 millimeter of the cornea is spared, so that the visual axis is normal, and the patients have nearly good vision, which is around 6/9 and more. However, in the presence of a grade 2, in which there is partial affection of the central 5 millimeter of the cornea, and the visual axis will be partially involved, so the patient will have reasonable also visual function between 612 to 660. Now, grade 3, which is the severe one, G2, involved the central total involved the central 5 millimeter and the visual axis area. So there will be marked profound affection of the visual function of the patients, and the vision will be 660 and less. So from this, you can understand that the staging system is based on the anatomical involvement, and it is important for planning for the surgical intervention. However, the grading system is related to the functional impairment, and it is important to determine the degree of urgency for the intervention as well as for the prognosis. So staging is a classification based on the extent of the location, as I said, how many percentage of limbus is involvement, and is there involvement of the central area or not. However, the grading is based on the functional affection or derangement in the visual function of the patients due to any inflammations, and this is useful for determining the urgency for intervention. So the International Limbal Stem Cell Deficiency Working Group recommend to use the staging for surgical planning, however, to use the grading for comprehensive assessment for the visual function of the patients. Now we come to the next point in the learning objectives, which is the evaluation and determine the indication for surgical interventions, and also plan for the medical and surgical management. And then finally, we will speak about the recent advances in the field of limbal stem cell therapy, ranging from the biofabricated or bioengineered corneas, the use of COMET, that's the cultivated oral mucosal epithelial transplantations, and the gene therapy, also the induced pluripotent stem cells derived corneal epithelium, also the use of bioengineering construction in the corneal organoids, and also the mesenchymal stem cell therapy principles. We'll go through this just a few words about them, so that you will be aware of where the stem cell therapy have reached. Now, the main task of this lecture, which is the management of limbal stem cell deficiency. Now, before speaking on the details of the management of limbal stem cell deficiency, we have to set up certain targets of our management. Of course, these targets, one of them is to restore the corneal epithelium. This is very important because by restoring the healthy corneal epithelium, we can guarantee the success of our management either by improving the residual limbal stem cells that's available, or enhance the success of the limbal stem cell transplant that we are planning to do. Another target of our management is to improve the visual function of the patients. Of course, we will improve the surface of the eye, but also we want to improve the visual function of the patients. And one of our targets also is to reduce the inflammation. By reducing the inflammations, we serve two purposes. Number one, we maintain the function of the residual healthy limbal stem cells, as well as we can guarantee the success of the transplant that we are going to do. And then at the end, we will prepare for any, after finishing all these preparations, we are ready for any further surgical interventions. So it is very important to optimize the surface of the eye and the ocular surface of the eye so that make the situation and the environment suitable for any further management in the form of limbal stem transplantations. This will guarantee the long-term survival of the transplant and enhances the function of the residual surviving limbal stem cells in a case of partial limbal stem cell deficiency, and also will improve the patient symptoms. So by understanding these targets, we will work so that we will try to fulfill these targets. Now, after we have knew about the staging of the limbal stem cell deficiency, this is important for us to plan our medical or surgical intervention for the patients. We have knew that we have three stages, stage 1, 2, 3, based on the involvement of the central 5 millimeter, and each stage is subdivided into A and B and C based on the limbal involvement. Now, if we have a partial disease, that means that we have still we have residual normal limbal stem cells and also normal epithelial cells of the cornea. So this based on the management based on the involvement of the visual axis. Now, if the patient is in stage 1, so as we have said before, that stage 1 there is a sparing of the central 5 millimeter. So usually the visual axis will be spared and there will be no affection. And in these cases, predominantly, we need just medical treatment for the patients in the form of anti-inflammatory or lubricants or elimination of the causative factors responsible for impairment of the function of the limbal stem cells. However, if there is involvement of the central 5 millimeter, that's to say stage 2, the first thing is to look for any associated factors that plays a role in reduction of the function of the limbal stem cells, like the presence of adnexial affection in the form of abnormality in the lid, or presence of dryness or any meibomian cell dysfunction, and so we have to treat them first before we target the limbal stem cells. However, if there is partial disease with affection of the central 5 millimeter, so up to stage 2A. Stage 2A means that there is less than 50% involvement of the limbal cells. So in these cases, medical treatment may be sufficient enough to restore the function of the remaining, to keep the function of the remaining limbal stem cells and restore the function of the damaged limbal stem cells. So for a partial disease with stage 1, stage 2A, we have a place for medical conservative management. However, if we go deeper and if there is also any associated factors in the form of severe fibrovascular pannus, we have to remove it by scraping or by what's known as superior sectorial conjunctival epitheliectomy. By scraping this pannus along with the abnormal conjunctival epithelium, this will allow space for multiplication of the normal corneal epithelium. As you can see, our management here in the partial disease up to stage 2A, there is a rule for medical treatment, steroids, anti-inflammatory, and so on, and also treat the associated abnormalities. As you can see here, this is a partial disease. You see the latest staining of the fluorescein, and still there is some residual normal epithelial cells. and this is the area of affected limbal stem cells, and there is a sparing in the central 5 millimeter. So you can see that this is stage 1P more than 50% involvement of the limbal cells. So there will be incomplete conjunctivization of the limbus and presence of residual limbal stem cells. So these cases can be managed medically only. Now, in cases of presence of a total limbal stem cell involvement, ranging from stage 2B, 2 means there is affection of the central 5 millimeter, so there will be some visual involvement, and B means that we have more than 50% involvement of the limbus, so there is no C in stage 2. So along with stage 3, these cases usually they need surgical interventions in the form of limbal stem cell transplantation, but still we have some cases in which there is a sparing of the visual eggs. As we said, in total involvement, you find some cases with total involvement of the limbal stem cells, but still they have spared visual eggs. This is not stage 1C. So these cases also may benefit from medical treatment alone. Now, what's bothering us or important for us in a total limbal stem cell disease with affection of the central 5 millimeter to determine whether your patient is unilateral or bilateral disease. This is very important because in the next slides, you understand how we plan our management in the presence of a total limbal stem cell disease based on the unilaterality. Unilateral disease open the door for autologous grafting. However, bilateral disease open the doors for allogenic graft that we will discuss later. So this is example of a total limbal stem cell disease characterized by total conjunctivalization of the cornea, the entire cornea, with complete loss of the corneal epithelial stem cells. So in these cases, as you can see, this is total staining, residual staining of fluorescein staining of the epithelium. This is because this is an abnormal conjunctival epithelium. So in these cases, we medical treatment alone is not enough in these cases, and it is mandatory to plan for surgical intervention, either just limbal stem cell transplant alone or combination of limbal stem cell transplant along with keratoplasty and so on. We will discuss later about the different types, as I said, based on the unilaterality of the disease. Now, after we have set up our priority, as I said earlier, and we have optimized the anterior ocular surface. Now, optimization of the anterior ocular surface is very important to secure and guarantee the success of your graft, and also to improve the symptoms of your patients, because we are preparing the environment to receive this guest which is coming, that is the limbal stem cells. So to guarantee the success of your surgery, you have to optimize the anterior surface. If there is dryness, if there is any inflammation, autoimmune disease, all this should be dealt with before we plan to do any graft operations. Another thing, that there are certain definitions and certain guidelines we have to follow so that we can choose the best and the ideal option for your patients. Now, the meaning of autograft, as you know, the autograft means the harvested cells are from the patient's own eye or from the contralateral healthy eye. So there is no any risk or any burden of immunological response that can be happens due to this implantation. That's why this type of operation is very successful, provided that you optimize the anterior ocular surface. So we prefer to use the autograft rather than the allograft, but the situation is which one, the clinical situation determines which type of graft you are going to choose. Now, the typical example of autograft is the conjunctival limbal autograft. That's the CLAL, CLET, and the CLET. That's cultivated limbal epithelial transplant. Later, we will speak about the meaning of cultivated limbal epithelial transplant. So the autograft is suitable usually for unilateral total cases because the contralateral eye will be healthy, so we can choose the graft from the other eye. Now, the allograft means that we are taking the cells from either a relative donor, relative to the patients, that's another person, or from the cadaver. And of course, since it is an allograft, there is a burden and there is a risk of immunological response. The typical example is the conjunctival limbal allograft. the Keratolimbal allograft and the allogenic CLET and allogenic CLET. Now, what are the indications of autograft? As I said, it is suitable for a unilateral total disease, provided the contralateral healthy eye. And you can put 2 lines below this word. You should guarantee and secure that the contralateral eye is very healthy, because if you are dealing with an autoimmune disease, even if it has asymmetric presentation with unilateral severe problem, but usually the other eye has subclinical inflammation. So by proper clinical examination and using whatever equipments you have, you should determine that the other contralateral eye is very healthy. Otherwise, you will induce heterogeneous limbal stem cell deficiency in the other eye. So there should be no any active inflammation in the other eye. There is no any evidence of limbal stem cell deficiency, and preferably use it in a young patients. Now, the indications for allograft, from the name implies, is for a bilateral severe disease. Because you have a bilateral disease, you cannot harvest any cells from the healthy eye. So you have to go for allograft, either from a donor, a relative donor, to guarantee compatible histocompatibility antigens, or from a cadaver. And this is usually indicated in autoimmune diseases, severe chemical injuries, severe ocular surface problems, provided that there is no high risk for rejection. Because if there is high risk of rejections, even for allograft, it is contraindicated, and you should go for another option like keratoprosthesis. Also, after failure of recurrent, after failure of recurrent autografts, you should go for allograft, or after failure of the mucosal or buccal cells. So this is also an indication for allografts. Now, the contraindication for autograft, as I said, that if there is contralateral eye is risky or borderline, you should not go for that. And if there is also operations like glaucoma or any prior surgery in the other eye, better not to go for the autograft. Now, the contraindication for allograft, if you have severe ocular surface problem with severe inflammation, that the success of your operation is not guaranteed, and if there is severe bilateral autoimmune disease, or if there is any contraindication for immune suppression, because in allograft you are going to use extensive immune suppression. Now, if your patient cannot tolerate the systemic immune suppression, so this is another contraindications, and you have to look for another option, as I said, like keratoprosthesis, or in the presence of active inflammations. So the home message, that keep it in your mind that any partial disease of limbal stem cell deficiency can be managed medically, and sometimes in a selected cases, minor surgery is needed, like just a amniotic membrane transplant, or doing the slit, that's simple limbal epithelial transplant. However, in a unilateral total disease, better to go for autologous graft, as I said, like slit or CLAL. And in the presence of bilateral disease, you have to go for allogenic graft. And if this allogenic graft is contraindicated or failed, you have to go for keratoprosthesis. Here's a summary for what we have said before, but in a more structured way and simple to memorize. That's in stage 1 limbal stem cell disease or deficiency, where usually sparing of the central 5 millimeter, and there is partial involvement of the limbal area, either stage substage A or B or C. Usually medical treatment predominate in this stage, and the use of anti-inflammatory and also immunosuppressive like cyclosporine, or we use autologous serum to improve the ocular surface. Also, lubricants is that's what we need. Sometimes we need mild surgical interventions for the adnexal areas, and the most common is removal of the pannus, removal by superficial keratectomy, and epitheliectomy, that's remove the surface of epithelium, which is mainly of conjunctival epithelium, to be replaced by the normal corneal epithelium. Also, we can do amniotic membrane transplant to improve the survival of the residual limbal stem cells by promote the healing of the surface of the epithelium, and also reduce the inflammations. Also, as I said, that limbal epithelial debridement might be needed, and as I said, that surgical intervention rarely needed in these cases. And don't forget that we might need adjuvant or adjunctive surgery at any level of the management by managing the associated adnexal pathology. If you have any lid entropion or ectropion, you have dryness, so you have to manage that in conjunction with the limbal stem cell. And if the patient has glaucoma, also you have to manage this glaucoma. Now for stage 2, which is just mild involvement of the central 5 millimeter, with which can be also subdivided into A and B based on the extension of the limbal involvement less than 50% or more than 50%. So in these cases, the surgical management is optional. The ground standard is the medical treatment should be applied first, and then the surgical management is optional if there is failure of medical treatment, there is no improvement of the patient's symptoms, and there is also progression or deterioration to an advanced disease. At that time, we have to interfere surgically, starting by the simplest way, which is the slit procedure that we will explain about it later on. That's simple limbal epithelial transplantation, especially if it is a unilateral pathology. However, if it is bilateral, there are other different options. And urgency is more for a single-eyed patients. And if there is a bilateral disease, we will go for allogenic graft with immunosuppression rather than autologous or allogenic autologous graft, I mean. Now, another options, that's the CLAU, that's conjunctival limbal autograft. We'll explain about this later. And many CLET and amniotic membrane adjunctive treatment. All this aim to restore the epithelial integrity and preserve the central visual axis. However, if there is deterioration of the central corneal epithelium, no improvement of the patients, we have to set up a more aggressive surgical interventions. So this is for stage 2. Now, for stage 3, we have 2 stages. We have stage 3 advanced stage, and we have stage 3 terminal or very late stage. Of course, from the name implied that stage 3 means there is much more involvement of the visual area and the central 5 millimeter, and there will be advanced limbal stem cell involvement. So even with medical treatment, there will be no much improvement for the patient's symptoms and complaints, and you need to go directly for surgical interventions, as I said before, based on the laterality, whether it is unilateral or bilateral disease. Broadly speaking, if it is unilateral, we'll go for autologous grafts. However, if it is bilateral, we'll go for allogenic grafts. There are a battery of different types of limbal stem transplantation. We will speak about them later on, but this is some of the examples like the slit, CLET, allogenic KLAL, and deep anterolamellar keratoplasty is an optional also. And of course, when we use allogenic grafts, we have to use or apply aggressive immune suppression. Now, if we have stage 3 but advanced stage, so that's a terminal or very late stage with pan-ocular disease with total limbal stem cell involvement. So at that time, as I said, we have to have more aggressive surgical interventions, namely the allogenic grafts with extensive immune suppressions, mucous membrane grafts that we can use from the buccal mucosa. We'll speak about this later. And the use of Boston keratoprosthesis is a strong option, especially if it is wet eye, there is no dryness, we can use type 1. And if it is a dry eye, we can use type 2. Now, this is example of the Boston prosthesis. This is type 1, and this is type 2. And actually, this is a multidisciplinary management because usually associated ocular surface problems and also associated secondary glaucomas. So we have to manage all these problems for these patients. Now, I will, in the next slides, we will speak in details about each and every type of the limbal stem transplantations. Now, it's the time to speak on each type or each variety of limbal stem cell transplantation. As you can see from this diagram that there is a lot and different varieties of limbal stem cell transplantations. Now we will break down these and we will speak on each one in detail so that we can know the difference between different types, also the indication for each one. Now, the first thing that we will speak is the conjunctival limbal autograft. And when we say autograft, it means from the same patient as from the healthy other eye, and this is usually for unilateral cases. So now the first thing, as I said, the conjunctival limbal autograft, abbreviated as CLAU, and is defined by a surgical procedure in which healthy limbal stem cells along with the adjacent conjunctiva are harvested from the patient's unaffected eye, so that we have a unilateral limbal stem cell disease. So this is suitable for unilateral cases in which you have one affected eye and one normal eye. So we harvest the part of the conjunctiva along with the limbus from the normal eye and implanted or transplanted into the other eye. So the indication in the presence of healthy fellow eye and stable ocular surface and adnexia, and there is no any autoimmune diseases. Now, the surgical technique, as I said, that 2 to 4 limbal biopsies, usually 2 from 6 o'clock position and 12 o'clock position, along with the adjacent conjunctiva is removed. And after removing of the pannus and the fibrovascular tissues present in the recipient eye, the graft is secured by using a fibrin glue or by 10-0 nylon sutures. Since it is an autograft, usually there is no need for immunosuppression. And the success rate of these cases is very high, reaching up to 90%. And it is very useful in restoring the stable ocular surface after this procedure. However, the visual function is dependent on the stromal haziness or the stromal status or clarity to determine the final visual acuity. Now, this diagram shows the conjunctival limbal autograft. This is the diseased eye, and this is the normal eye. Now, the diseased eye, first of all, they remove the fibrovascular pannus and secure that the ocular surface is healthy. And then from the donor eye, a piece of the conjunctival limbal autograft is removed from the 6 and the 12 o'clock positions, and then is placed in the normal saline or BSS solution. And then it is secured by fibrin glue or by 10-0 sutures to the limbus. And within 6 to 8 weeks, you will find significant improvement in the ocular surface and also the residual staining of the cornea. And also the visual function is dependent on the clarity of the stroma. This type of procedure is there is some limitation that the risk for the induction of limbal stem cells in the donor eye, which is known as heterogeneous limbal stem cell, if you take the biopsy more than 6 clock hours. So it is advised not more than 1 to 2 clock hours from each side. So totally 4 clock hours should be removed, not more than this. And this type is not suitable for bilateral cases because the chance of heterogeneous limbal stem cell deficiency is high. If you have, for example, diseased eye and you have a partial healthy limbal stem cells, you cannot take the risk and remove that part and implant it into the other eye. And the other limitation that this type of implantation, if it is failed, better not to repeat them and go for another way of transplantations. So this is briefly about the conjunctival limbal autograft. The second variety of limbal stem cell transplant is known as the CLET, which stands for simple limbal epithelial transplantation. And this type, or in comparison to the previous one, that's the conjunctival limbal epithelial transplantation, that we only use limbal epithelial cells without the incorporation of conjunctiva. We will speak about this in details. So SLIT stands for simple limbal epithelial cell transplantation, which was invented by Werner Sangwang in 2012. And it is simply that we harvest a small seeds from limbal stem cells of 2 × 2 millimeter, and then is fragmented for small pieces placed onto the surface of amniotic membrane, which is placed into the diseased eye. So this allows for in vivo expansion of these cells without the need for any laboratory expansion. And the cells or the explants is secured by applying a fibrin glue. And then we apply a bandage contact lens on the surface of these complexion. Now, the indication for this type of cell implantation is, as I said, that in unilateral cases, in any cases like chemical injuries, post-infectious cases, and post-contact lens limbal stem cell deficiency, and also in both surgical cases, and also in what's known as the heterogeneous limbal stem cell deficiency. It is a simple technique and shows a very promising and good result, provided, as I said, that we utilize a very good amniotic membrane. We will speak later about the types of amniotic membranes, because this also will affect the final result, is the type, whether you use a dry or wet type or fresh type of amniotic membrane. So this diagram shows the seeds of the limbal stem cells that we harvested, and we then defragment to small pieces and place it onto the amniotic membrane on the surface of the contralateral diseased eye, and then secured by applying glue, and then we put a bandage contact lens. So this acts as a in vivo expansion for the cells, and we don't need for any laboratory expansion for these cells. This is simply the simple limbal epithelial cell transplantation. Now, what's the limitation or the contraindication for this procedure? That this procedure is only applicable in unilateral cases, that you must have a normal contralateral eye, so that you can harvest the limbal seeds from that eye and transplant it to the other eye. Another thing, that you need an intact stromal bed and relatively non-inflamed ocular surface. To allow for the expansion for these cells in a healthy way, you need to have a normal stromal bed as well as no inflammation, because this is in vivo proliferation or expansion of the cells. So you need to have a completely stable, inflammation-free surface of the eye. So the contraindication will be in bilateral cases, in which there is especially autoimmune diseases like ocular cicatricial pemphigoids and active Stevens-Johnson syndrome, the presence of severe dry eye, and either a dry eye, evaporative dry eye, or severe aqueous deficiency dry eye. Also in the presence of ocular surface problems like symplepharon, severe conjunctivization, that's not amenable for amniotic membrane support. All these are limitations for the success of this type of procedure. Now, the key advantage of this type of procedure is that it is a single stage of procedure done at one stage. You don't need to do it in a two stages of procedure, and it avoids any laboratory-based expansion, unlike the CLET that we will speak about it later. So it is in vivo expansion, and minimal donor tissue required, because the other eye is healthy, so we need a very small and minimal tissues, and it is very replicable, that if it is failed, we can do it another time without any much cost for the patients. Now we come to the third type of the limbal stem cell transplants, which is the CLET, which stands for Cultivated Limbal Epithelial Transplant. And as the name implies, that's a cultivated stem cells. That is the sample of the limbal stem cells before being transplanted to the recipient eye is grown into a laboratory culture, which is known as ex vivo stem cell expansion. Ex vivo stem cell expansions. I will explain about this. And after 2 to 3 weeks, this cellular sheet is transplanted to the recipient eye. So it is a two-stage procedure, and it needs special laboratory facilities to do this type of stem cell transplantation. So the CLET, as I said, it is a cultivated limbal epithelial cell transplantation, which is a two-staged procedure, utilizes the tissue engineering technology and the donor limbal stem cells, which is harvested from 1 to 2 millimeter from the healthy limbus, either from the contralateral eye. So it can be used for a unilateral limbal stem cell deficiency, or even with bilateral disease, because the sample needed in this type of limbal stem cell transplantation is very small. So the risk of inducing heterogeneous limbal stem cell deficiency in the donor eye is very low. So even in the presence of bilateral disease, we can have a very small sample from the diseased eye or the affected eye, provided we secure that part of the limbus that we take the sample from it is preserved and free of any abnormalities. And once this is taken, is grown into a special culture, usually human amniotic membrane or fibrin substrate, for 2 to 3 weeks in the lab. And this lab should have a good standard with the GMB certificate, so that avoid any complications, other complications due to this tissue expansion, like the infection and contaminations. Now, this diagrammatic representation of the procedure, that this is the normal eye, that's the donor eye, and this is the diseased eye. The diseased eye, we perform 360-degree periotomy and remove if there is any fibrovascular vannus. And the donor eye, 1 to 2 millimeter limbal tissue is harvested. And this harvested stem cells expand in the laboratory in amniotic membrane sheet or in fibrin substrate in the lab. And after 2 to 3 weeks, the cellular sheet is transplanted onto the recipient eye, and it depends on the type of a graft. So if it is autologous CLET, autologous means that we take the sample from the contralateral eye. So in this case, there is no need for immune suppression. However, if it is not autologous graft, it is an allograft, either from other living related allograft or from cadaveric allograft, so we will need to apply immune suppression in these cases. So this is very important to be clear. Now, as I said, the indication, it is suitable for unilateral cases and also for bilateral cases in which there is no 100% involvement, because we need a very small sample. So there is no risk for inducing limbal stem cell deficiency in the donor eye. And it is suitable for different types of limbal stem cell diseases due to chemical injuries or thermal injuries or autoimmune and Stevens-Johnson syndrome, aniridia, and contact lenses and so on. So this is the indication. And there are certain limitations and contraindication for this type. The limitation that it is a two-stage procedure, so you cannot do it in the same setting to your patients. You have to take the biopsy first, then you grow it in a cell culture, then you come back and do the transplantation. And as I said, you are dependent on the laboratory for the tissue culture, so that you need a high standard laboratory certificates, which is the GMP, to secure the tissue culture so that you can transplant the cells to the recipient eye. And since you need a specialized laboratory, so it is an expensive procedure, which means that it is not amenable for every and each one. And as I said, it is a two-stage procedure. You need 2 to 3 weeks, and immune suppression is needed if it is an allogenic CLET. Allogenic means that you've taken the donor stem cells from either life-related CLET or life-related donor, or from the cadaver, that's from the graft, from the tissue bank. So systemic suppression is optional, depends on the type of the graft. If it is autologous CLET, so no need for systemic immune suppression. Of course, as any type of limbal stem cell transplant, in the presence of active inflammations, it is forbidden and better not to do the operation in the presence of active inflammations, or if there is severe keratinization of the cornea with severe dryness. You have to treat the associated accompanying ocular surface pathology before you start to contemplate the limbal stem cell procedures. And also in the presence of severe conjunctival fibrosis and symplepharon, you have to treat the adnexia first, and then you go ahead with this type of operations. So the key advantage of this type of operation, it is useful for bilateral and even unilateral, unlike the SLIT, which is useful only in unilateral cases. And it allows standardized cell expansion and quality control because you grown it in a specialized laboratory, and there is no risk for inducing limbal stem cell in the donor eye because you need a very small limbal harvest. And as I said, can be used with allogenic source. That's, you can use it from life-related source or from cadaveric donor. Now we come to the fourth type of limbal stem cell transplant, which is known as the Keratolimbal allograft, KLAL. Now, Keratolimbal allograft, since it is an allograft, so the source is from the donor. The donor cornea is from the tissue bank, that's from the cadaver. So the issue of immunosuppression is very strongly indicated in these cases. We will explain about this in details. So the Keratolimbal allograft defined as the surgical technique where cadaveric limbal tissue from the whole eye is transplanted to restore the limbal stem cell population in patients with bilateral limbal stem cell disease. So the main indication for this type of limbal stem cell transplantation in the presence of bilateral total limbal stem cell deficiency. So when you have a patient with bilateral disease and it is severe that you don't find any normal limbal stem cells, so the only option for you is to receive donation from the cadaveric cornea. And in that situation, we will harvest 360-degree limbus from the cadaveric cornea and transplant it to the recipient eye. So it is useful in bilateral advanced disease or in presence even of unilateral disease, but the contralateral eye has any disease that prevent or make it at risk if we take any sample from it, like for example, in the presence of advanced aniridia, or if you have tried an autologous graft but it is failed, so at that time you should go for the Keratolimbal allograft. So Keratolimbal allograft, that we transplant the limbus from the cadaveric cornea. This is as simple as that. Now the procedure the same. This is the diseased eye. So we do 360-degree periotomy and removing the fibrovascular panels, make this eye is ready. And then we harvest the keratolimbal area 360-degree from the cadaveric cornea, and we divide it into 3 pieces and secure it by sutures around the limbus of the recipient eye in this case. So plus minus we might add amniotic membrane based on the ocular surface, and this provide a very good source and pool for limbal epithelial stem cells. Now the advantage that it provides large stem cell pool and it is useful in a bilateral disease, and it can be combined with penetrating keratoplasty. If you have any stromal haziness in the cornea, so we can combine penetrating keratoplasty along with the keratolimbal allograft. Also sometimes combined with Boston prosthesis. The limitation, it requires systemic immune suppressions, and the risk of rejection is very high as compared to the autologous grafts, and progressive limbal ischemia and stromal scarring is at risk also, and the graft survival decrease over time, so the lifespan for the graft is 5 to 10 years. So this is some of the limitations of this type of stem cell transplant. As I said, that since it is an allograft, so the question of immunosuppression is very strongly recommended. So the patient will need to stay for a long time on immunosuppressions like oral cyclosporine and also steroids, and the risk of injection, risk of infection is there, and epithelial rejections and also graft thinning is there. All these should be monitored carefully post-operatively. However, the outcomes within short term is 60 to 80%, and on long term is about 40 to 60%. And provided the good prognostic factor is the presence of good ocular surface and adequate eyelid and tear support, all this is a good prognostic factors. Now we come to the fifth type of limbal stem cell transplant, which is living-related conjunctival limbal allograft. Now, in this type, it is abbreviated as Lr-CLAL. So it is a living related. It means that we choose a living person who is very closely related to the patient. So we can harvest the conjunctival limbal tissue from him. So this is an allograft tissue and transplant it to that patient. In the living related conjunctival limbal allograft, that we take the tissue from a close relative to the patients, so that we minimize the risk of rejection as compared to the KLAL, that is the keratolimbal allograft, as you know, that is taken from the cadaveric cornea. However, here, due to the absence of the cadaveric cornea, we take the living related conjunctival limbal allograft, that we take the conjunctival epithelium along with the limbal epithelium from closely related person to the patient, so that we have a high match of HLA typing and minimize the risk of rejection. So it is indicated in the presence of bilateral severe disease and in the absence of cadaveric source. And it is applicable for any cause of limbal stem cell deficiency due to chemical burn, Stevens-Johnson syndrome, aniridia, or any other causes due to immunological causes, provided that there is contraindication or there is no cadaveric source. The surgical concept is the same, that we harvest a superior and or inferior limbal tissue that is containing the conjunctiva and the limbal tissue from 1 to 2 quadrants, and in a closely related donor. After performing the HLA typing and other criteria, selection criteria, we will speak about them later. What are the different tests that we have to perform to the donor so that we can secure no rejection will happen or very minimum risk. And also they transplanted on a vascularized recipient ocular surface after the penis and removal. So you have to remove the penis first and then you transplant it, or you can use even amniotic membrane graft on the top of this transplant to secure the ocular surface. Now, the advantage of this type of the procedure that the risk of rejection is low as compared to the KLAL, and no delay due to cadaveric tissue processing, so it is very rapid procedure, and the rapid epithelialization and stability of the ocular surface will take place. Now, the limitation for this type that you require an HLA compatible donor, so that you have to perform a battery of laboratory investigation with different antigen, laboratory antigen compatibility, so that you secure that there is no risk of rejections. And of course, even with a highly compatible donor, you need still immunosuppression, but the risk of rejection is low as compared to the KLAL, as I have mentioned before. And that's why postoperatively you have to monitor the immunological reaction, epithelial rejections, the ocular surface, any signs of inflammation or surface instability. All this should be monitored carefully postoperatively. Now, the outcomes is better than the KLAL, so that in short term it is 50% to 70%, and on long term 30 to 50%, and better outcome as compared to the KLAL, especially if there is no ocular surface pathology or inflammations. So the success rate for these cases is much higher. Now, as I said, that for the living-related conjunctival limbal keratoplasty, we need to do selection criteria for the donor. Now, there are certain investigations that we have to perform for the donor so that we minimize the risk of immune rejection of the graft. So the purpose of this donor selection is to minimize the antigenic burden and to reduce the risk of graft rejection and maximize the stem cell viability and long-term success. So what are the selection criteria for the living-related conjunctival limbal allografts? Now, first of all, we have to identify the first-degree relative, preferred to be genetically compatible, because the first degree, the closer the person to the patients, will be more genetically compatible. Then we will perform the ABO antigen, blood group antigen, and find out the compatibility. Then we perform certain immunological testing, which is known as the panel reactive antibody and the donor-specific antibodies. All these should be matched and compatible. And then finally, we'll go, if this is matched and compatible, we will go for the HLA typing. Now, before we go to the HLA typing, if there is any incompatibility in these tests, so we will not go for the HLA typing and we will change the patients. However, if all of these are compatible, ABO, BRA, and DSA, at that time we will go for HLA typing for searching for cross-matching and for compatibility. Now, other serological tests are very important as an infectious screening for HIV, type 1 and type 2, hepatitis A and B and C, and cytomegalovirus. Of course, this should be done to avoid any transfer of infection from the donor to the recipient. So the home message that you have to keep it in your mind after our previous discussion, that is the Keratolimbal allograft is ideal for bilateral total limbal stem cell disease, but requires long-term systemic immune suppression because this is totally allogenic graft. However, in living-related conjunctival limbal allograft, the option of bilateral disease when cadaveric tissues is not available and the donor risk is concerned. Now, for the CLET, as I said, that it is best for unilateral diseases, but also can be used for bilateral cases because very small tissue you need for the CLET. And if it is autologous CLET, you don't need systemic steroids. However, if it is allogenic CLET, so at that time you need to use steroids. Now, the best one and useful for unilateral cases is the SLET, and there is no need for steroids because it is totally autologous graft. Now we come to another type of epithelial cell transplantation that is done for limbal stem cell deficiency, but this is not typical for a stem cell transplant. This is not a stem cell transplantation, but it is an epithelial transplantation because in the COMET, which is cultivated oral mucosal epithelial transplantation, we harvest the donor from the same patient from the buccal mucosa. So that buccal mucosa doesn't contain the stem cells, it is just an epithelial cells. So it is not identical for the corneal epithelial cells. But the aim for this type of procedure is to maintain the ocular surface and secure healthy ocular surface and a preliminary step for subsequent keratoplasty or keratoprosthesis later on. So it is not an ideal, we should not name this as stem cell transplant, but this is a epithelial cell transplant known as COMET, that is cultivated oral mucosal epithelial cell transplantation. Now, as I said before, it is defined that type of cell-based therapy, it is not a stem cell therapy, but it is a cell-based therapy. And the advantage that it is autologous because we utilize the oral mucosa epithelium to harvest a small piece of tissues and then transplant it into the ocular surface after being cultivated in a special tissue culture or in amniotic membrane. So it is retransplanted again to the patient. So the aim is to reconstruct the corneal epithelium in a patient with a bilateral limbal stem cell disease, and he is not fit for allogenic graft because he cannot tolerate the immunosuppression, the extensive immunosuppression needed after any allogenic graft. This patient cannot tolerate it for any reason, and he has bilateral advanced disease. So one of these options is to secure his ocular surface as a preliminary step for subsequent keratoplasty or keratoprosthesis later on. So we'll do this COMET to improve the ocular surface. So as I said, it is useful in bilateral total limbal stem cell deficiency, like in a severe Stevens-Johnson syndrome or ocular cicatricial pemphigoid. And the patient is unsuitable for any allograft transplantation because he cannot tolerate the immunosuppression. Now the technique, as I said, we harvest a small piece of tissues 2 to 3 millimeter from the buccal mucosa under local anesthesia, and this is get cultivated on or cultured on denuded human amniotic membrane or fibrin scaffold in a special lab. Then transplanted back this tissue or this cultivated epithelial sheet is transplanted into the prepared ocular surface after removing any fibrovascular pannus or any abnormalities. Now the advantage, as I said, it is an autologous, so there is no need for immunosuppression, no systemic immunosuppression, safe for patients with severe disease and bilateral disease. And reconstruction, it is very useful for reconstruction of the epithelium and improving the comfort and ocular surface stability to improve the comfort of the patients. Now this diagram shows the COMET. So we take a sample from the buccal mucosa and then get denuded and harvested after harvesting and get cultured on the amniotic membrane or fibrin substrate. And then after a few weeks, it is retransplanted back to the ocular surface. This is the diagrammatic representation for this type of epithelial transplantation rather than stem cell transplantation. Now the limitation that the oral mucosal epithelium is not true corneal epithelium. This is very important. So the oral mucosal epithelium is not a true corneal epithelium. So it is not ideal and there is suboptimal optical quality. Now the vision will vary, depends on the patient situations. We cannot guarantee clear cornea because there will be some hazy surface because this buccal epithelium is not ideal as corneal epithelium. The corneal epithelial phenotype is not guaranteed. Now, no corneal specific stem cells, they're only epithelium. There is no stem cells, so no visual improvement is guaranteed, and requires advanced laboratory facilities for the cell culture, this type of cell culture. So the risk of new vascularization is there, and the risk of recurrence of the inflammation is still there. However, the surface stability is guaranteed in 70 to 80% of the cases. Visual improvement, as I said, it is not guaranteed, and it is limited by the non-corneal epithelial phenotypes, because this epithelium is not like the corneal epithelium. And it provides a better symptomatic relief and better integrity for the ocular surface. And as I said, this is a bridge for future keratoplasties or optical keratoplasty. This is the aim for this type of procedure in a patient with advanced bilateral disease, and we cannot do allogenic transplantations, so that we will go for this type of procedure to secure a healthy integrated ocular surface. Lastly, but not the least, that we will speak now about the combination of different procedures that's treating the ocular surface as well as stem cell transplantation. So this is a combination procedure abbreviated as OSST. That's we do a procedure to treat the ocular surface as well as we do stem cell transplantation. So these procedures involves two or more surgical interventions performed simultaneously or sequentially to restore both the limbal stem cells and the ocular surface integrity. Why we combine these two procedures? Because some patients, they have multifactorial pathology. They have limbal stem cell disease along with conjunctival scarring, sometimes dryness and stromal opacities. So our aim is to secure and optimize the visual rehabilitation and also secure the survival of the graft. So we are obliged to do more than one surgical procedure at the same time to satisfy and fulfill these goals. Now, the advantage that it is tailored to complex cases only, and we will utilize a synergistic effect of the two procedures that's used to improve the ocular surface as well as the success of the graft. And better anatomical and visual outcomes is hoped after these procedures. I will show some of the commonly used combinations procedures, like the living-related conjunctival limbal allograft plus amniotic membrane transplant. And this limbal restoration and utilizes the benefit of the amniotic membrane as anti-inflammatory and as epithelial scaffold. And this is indicated in limbal stem cell with severe conjunctival inflammations and ulcers. Another combination that we combine the Keratolimbal allogenic graft with penetrating keratoplasty. This is when there is stromal scarring. So we do the limbal stem cell along with the penetrating keratoplasty. Also, we can combine the CLET with the SLIT along with the amniotic membrane, especially if there is epithelial defect, persistent epithelial defect. Also, we can combine the COMET with amniotic membrane to secure the ocular surface, as we have explained before. So these combinations therapy is known as OSST. Now, after we have finished discussing all the classical and current modalities of treatment of limbal stem cell deficiency, we come now to the recent advances in the limbal stem cell therapy. A few words regarding the recent advances in the limbal stem cell therapy. We will discuss the recent or the latest advances in the limbal stem cell therapy in four aspects. Number one, advancement in the ex vivo cell expansion. That's the laboratory cell culture. Then there is advancement in the type of the cells used, either the limbal stem cells or mesenchymal stem cells or other cells. Also, there is advancement in the gene therapy and advancement in the biofabricated cornea. So we will discuss the latest advance in these four aspects, and we will start with the advancement in the ex vivo cell expansion. Now, the first line of advancement in the field of limbal stem cell therapy is what's known the ex vivo cell expansion. And as I said before, the meaning of ex vivo, it means that we take or harvest the donor limbal epithelial cells and grow them in the lab in a special culture. And then in a second stage, we transplant it back to the recipient eye. Of course, it is not as simple as this, but it goes through a very strict process of sterilization and supervision. And the implant is grown initially in a fibril gel and amniotic membrane under good manufacturing conditions, and then transplanted back to the recipient eye. The most and the first stem cell therapy approved in the European Union is known as the Lr-CLAL, which is not yet FDA approved based on this same principle. Usually we need a small tissue of 1 or 2 millimeter from the donor eye, and then, as I said, grow and cultivate it in this culture media, and then they make it as a fibrin membrane, which is inserted under the conjunctiva of the recipient eye and grown within 4 to 6 weeks. So this diagram shows the symbol, the representation of the cultivated autologous limbal epithelial cells. As you can see, we take the donor epithelial cells from the healthy eye, then we grow it in a special culture in the lab, and then transplant it back to the patient's eye. So this is a two-stage procedures that done, and this is one of the recent advances in the limbal stem cell therapy. Another advancement that the cell cultures now known as xeno-free media or serum-free. So it is totally devoid of any animal source of cells or serum, so that so that the risk of immunogenicity and rejection is not there. So they use a human platelet lysate or human serum for this media. This is also another advancement known as xenobiotic free and serum free, that is devoid of any animal source of culture media. Now, the second line of advancement in the limbal stem cell therapy is advancement in the type of the cells that are used. As you know, when this field of modality of treatment is innovated, it was basically dependent on the adult type of limbal stem cells. However, now start using what's known as induced pluripotent stem cells, and we have explained earlier the meaning of pluripotent cells. These induced pluripotent stem cells taken or induced by genetic engineering so that they became programmed adult type of limbal stem cells. And these cells will provide a very good source for autologous allografts, and where there is less immunological burden to the eye, so that there will be very low risk of rejection. However, as you know, for any genetically programmed cells, these cells they carry the risk of instability and the risk of transformation to a malignant cells, and also they might undergo some immunological changes. So this field also is still growing on, but still not, as I said, completely FDA approved. Now, the other type of advancement is the still the same use of type of cells is the use of mesenchymal stem cells. Now, the mesenchymal stem cells are derived from bone marrow or umbilical cord or adipose tissues. They don't differentiate to the corneal epithelial cells, but they act as a modulator that modulate the inflammatory response, and hence it is used in the as adjuvant therapy with limbal stem cell therapy to reduce the risk of rejection. And by this mesenchymal stem cells, they secrete a lot of growth factors and trophic hormones, so that will dampen the immunological response and will help to control the inflammation, especially in the ocular surface. So it is a adjuvant therapy for limbal stem cell therapy to enhance the epithelial healing. This is known as mesenchymal stem cells. Also, in the field of type of cells, they start using oral mucosal cells. And these oral mucosal cells, they are not stem cells, but they are somatic cells, but are used to help to differentiate and improve the ocular surface. As I said, prepare the microenvironment for the limbal stem cells to proliferate, and also the niche formation of limbal stem cells. In the next slides, we will discuss about the difference between mesenchymal stem cells and epithelial stem cells, so that it becomes very clear for you what's the source of these cells and what's the role of these cells in limbal stem cell therapy. Now, since we have spoken about the use of mesenchymal stem cells in the treatment of limbal stem cell deficiency or disease, so this is a broad difference between the limbal stem cell transplant and mesenchymal stem cell transplant. We'll go quickly through it. And limbal stem cells that we are transplanting limbal epithelial stem cells, which usually harvested from the limbus. However, for the mesenchymal stem cells, are harvested from the umbilical cord or from the bone marrow or adipose tissue. They have immune modulatory functions. They will not help to form the corneal epithelium, but they assist the or modulate the immunological response. Now, the target conditions, limbal stem cell deficiency. So they restore the corneal epithelium. However, mesenchymal stem cell therapy mainly used for ocular surface inflammations and adjuvant therapy to the limbal stem cell therapy, because they don't help in the formation of the corneal epithelium, but they support the formation of the corneal epithelium. So in the limbal stem cells, they directly form the or regenerate the corneal epithelium. However, this type, the mesenchymal stem cells, they modulate the inflammation by promoting the healing and support the angiogenesis and prepare the microenvironment for the niche cells of limbal stem cells for growth and multiplication. So mesenchymal stem cells, mainly they have adjuvant effect and supportive effect for the limbal stem cell therapy. Now, as far as the culture, the limbal stem cell can be grown in the lab, known as ex vivo expansion or the Lr-CLAL that we have said before. However, the mesenchymal stem cells can be used freshly without any culture. One of the main advantage of the mesenchymal stem cells is that they have immunological modulator effect. They have no immunological induced response. This is known as immunologically privileged cells. So they have immune modulatory effect and they don't have risk of rejection. Like the epithelial stem cells, if we exclude the autologous graft, the allogenic graft has risk of rejection. And as far as the approval for use, still the mesenchymal stem cells under experimental levels, even to large extent, a lot of procedures from the limbal stem cells are still under experiments, but there is some generalized agreement and used by most of the doctors. So this is broadly a gross difference between limbal stem cell transplant or limbal stem cell transplantation and mesenchymal stem cell transplantation. In summary, the limbal stem cells transplant replaces the missing epithelial stem cells and help to regenerate the transparent cornea. However, the mesenchymal stem cell transplant just only modulate the immunological response so that they will promote the healing of the cornea. So the mesenchymal stem cells, they have a supportive function. However, limbal stem cells help in the formation of clear, transparent cornea. And this mesenchymal stem cell therapy use it as adjuvant to the limbal stem cell therapy. So there is no contradiction between both. They can apply both together because they support each other. Now we come to the third line of advancement in the limbal stem cell therapy is the advancement in the gene therapy and the modulation of the mutations happens in the genes, especially in genetic diseases like congenital aniridia and the mutation related to the B63, as we have explained before. This field is still evolving and it aims to improve the survival of limbal stem cells and improve the differentiation of the limbal stem cells. The fourth line of advancement is the what's known as the biofabricated cornea. So this is really what's known as artificial cornea, in which three-dimensional bioprinting of this cornea is made by special ink known as bio ink, which is a mixture of collagen and decellularized corneal extracellular matrix with enhanced stem cells or induced pluripotent stem cells. All this ink is placed in a special machine, sometimes mixed with another or hybrid with another synthetic material, so lead to the hybrid synthetic cornea. So this is one way of advancement is the formation of biofabricated cornea, so that perhaps in the future there will be no need for corneal grafting or harvesting the cornea from the cadaver because of the availability of this technology. Before we close the discussion regarding the use of limbal stem cell therapy in the treatment of limbal stem cell deficiency, I would like to remind you that all these lines of regenerative therapy are still not FDA approved and still in the level of clinical trials. And the reason for that the FDA applies strict rules and regulatory acts that supervise and try to validate this type of treatment in the safe level. And the reason for that, there are a lot of moral and ethical obstacles facing this type of therapy, especially for the use of pluripotent stem cells and embryonal stem cells. As you know that the pluripotent and embryonal stem cells, they can differentiate to any type of adult cells. And especially for embryonal stem cells, when you are going to use these cells, this means that you are going to destroy the embryo, because the cells will be taken from the 5th to 7th day from the blastocyst formation. And this, of course, will create a problem from different religions and cultures. That's why there is a strict regulation for this type of treatment. Another thing that still there are certain questions and concern regarding the safety of this type of treatment as far as the for what's known as the functional equivalence. Now, the question that when you create a limbal stem cell from a pluripotent stem cell, is this synthesized cells are functionally equivalent to the native stem cells or not? This is one question. Number two, is it immunologically stable, that there is no risk of immunological reactions? And is it genetically stable, that it will not be converted to a tumor cells or becomes teratogenic? So still these questions are not answered, and there is no guarantee that these cells will be stable for long time. And this create an ethical concern as well as a technical cautions that there should be a very strict rule for the approval of this type of treatment. Although doctors and many centers, they are trying to using these cells either under supervision from the FDA as a trials or as an off-label modality of treatment, but the final approval is still not given. So this is, you should keep it in your mind, and the future carries a lot for this modality of regenerative treatment. Now, by this level, we have reached to the end of this lecture. We do our best to try to explain to you what we know about the stem cells and their indications and everything regarding stem cells. As I said, this lecture is important not only just for scientific advances and not only just important for your exam, but it is an important topic for your feeling the profound capability and the incredible power of our God to create such a small tiny cells that are capable for this regenerations. I hope that you have benefited from this lecture and you have enjoyed this lecture. Looking forward to meet you soon in another session. At that time, I hope for you the peace and good of luck, and thank you very much for your audience. And I am ready for any discussion regarding any point in this lecture. Just contact me on the channel, and thank you again for your audience.